Hi, everybody. I'm so happy that you all could come out and be the audience for this debate. It's very exciting. It's the first debate that I've heard of at SLU, and I've been here a long time. So please enjoy yourselves and share your ideas. There will be some time a little bit later in the debate for our audience to participate with questions. So we appreciate all of your input. And hopefully you'll vote after the debate and we'll see who wins. So our debaters, I'm going to go ahead and introduce them, are Dr. Weisbart and Dr. Josh Umbehr, but Dr. Josh is what he goes by. Dr. Weisbart is actually a faculty member at Washington University, but spent a great deal of his career here in St. Louis at Express Scripts as the CMO. And later retired, and he is the Missouri chapter chair for Physicians for a National Health Program. Has very interesting perspective on physician leadership and strategy operations. And Dr. Josh is a family practice provider who started his own concierge practice called Atlas that has created a lot of buzz and seems to be quite a success, and it's a completely different physician practice model that gives them a completely unique perspective on the healthcare system. So I'd like to welcome our speakers and thank them for coming out before they start. Thank you. The debate is on the resolution that single payer is an effective way to reduce cost and improve healthcare outcomes. Our first speaker is for this resolution, and it's Dr. Weisbart.
Can you hear me? Well, you're recording me. Hello. How do we get that? Is that good? Yes. That was good. Oh, I shouldn't spoke. Well, there we go. Hello. So, just by curiosity, how many of you were here at the noon presentation that I gave on Tuesday? And how many of you were here at the noon presentation that Josh gave? So a lot of you are sort of familiar with the issue. Anyway, I'm really glad that we're having this discussion, and I applaud you for inviting us and making this happen. So, my background, as you started to hear, is in medicine primarily, and then also in business. I'm a family medicine physician. I practiced for 20 years in Chicago, delivering babies, taking care of old folks, and everything that you can imagine in between. There weren't hospitalists, we took care of the ICU, we did all of that stuff. And when I moved here to St. Louis, I started volunteering at WashU, seeing patients in the medicine clinic as well. So clinician is at my core, in my mind, of who I am. Managed medical groups with 150 physicians when I was in Chicago. And then here, as you heard, I became chief medical officer at Express Scripts. So I kind of learned a lot of a business emphasis on how to analyze issues, and it became important to me, as you'll see. So. The organization that I chair, the Missouri chapter of Physicians for a National Health Program, is the group that advocates for a single-payer national health insurance program. We have a tremendous explosion of growth these days in students, so hooray for having student chapters and resident chapters. And our mission is very simple, just basically improve Medicare, because Medicare is far from perfect, and provide that to everybody. And we'll walk through that in a little bit more detail. So the problems, I think Dr. Josh and I will agree upon, in large part. Here's the first of the problems, that our life expectancy is awful. Here we are on the left. Here's countries where people all live longer than we do. So it's hard to argue that our system today is working well when all of those countries have longer life expectancies. It's not just the healthcare system, but it's certainly a factor. And our expenses are high. I think we all probably agree that that's an issue. We spend more than double most other countries. We also spend a lot on billing and insurance administration. Again, another point that we agree upon. Here's what billing and insurance administration costs in each of those categories on average in countries that have a national health insurance program. And then here's what we spend in addition to what those countries spend. So we spend a lot of money on that. And the result of the cost of our healthcare is that a lot of people simply can't afford it. These are non-poor adults, you can see insured and even uninsured and even insured, if they had to reach the deductible of a high deductible healthcare plan, they couldn't do it. Most folks can't find $3,000 to borrow from friends or family. They can't meet a high deductible, and as a result, people who rely on those kinds of plans are really stuck high and dry until they have problems. That's the key driver of bankruptcy, as you probably know. So what we think is a good solution to this is to improve Medicare and provide that to everybody. So improve that and expand it to everybody. Improving it means fix the benefit design. There's a lot of things that people with Medicare can't get. For example, they can't go see a nutritionist. Fix the benefit design. Eliminate the financial barriers. Medicare today has a lot of people, most people in Medicare, they have large deductibles and co-pays that are in the way of their getting access to health care. So we think we should not make that be the case, eliminate them. And most seniors who can afford to know about these problems, and so they purchase a supplemental wrap or a supplement or some other thing to wrap around their insurance, their Medicare, to expand it and improve it. And if you did what we want to do, no one would have to buy that because those improvements would be baked in. So you would eliminate the financial barriers and improve the benefit design. And then give it to everybody. Give it to Congress, give it to the president, give it to the mayor, give it to Josh, give it to everybody. And you could roll up all of the other programs. And if you did that, then we wouldn't have to be having these arcane fights that we have about whether or not to expand programs like Medicaid, because we would all have access to health care. So why should the solution that I'm proposing be based on Medicare? Why Medicare? Why is that the core of what I'm talking about? And I'll tell you that there's a few reasons. First, despite what you may have read in some of the popular press, Medicare is incredibly efficient. So here's the overhead, the reported SEC filing overheads for the first half of this year of those major large insurance companies. And here's the overhead of traditional Medicare, 1.4%. That's all in. That's including what it costs to have the IRS collect the taxes to pay for, it's the rent. That's all in. Medicare's overhead reported is 1.4%. If you, as traditional Medicare, Parts A and B, if you include the overhead that's required for the privatized version of Medicare, Part C and Part D, overhead goes up to 6%. So Medicare's overhead is remarkably low. It should probably be a little bit higher than that 1.4%. There should be a few more things, but there's no comparison. There's no argument with it. Medicare is not economically highly efficient. And it has a remarkable effect on life expectancy. So this is a wonky chart, and I apologize for that, but here's our ranking as Americans against 17 peer nations for life expectancy by age. So there's, 5-year-olds as they compare it to 5-year-olds in 17 other peer nations. And it turns out that until you hit Medicare age, we're the worst of 17 peer modern nations. All the ones you would think, Italy, Sweden, Japan, France, we're the worst of 17. And when we turn 65, we rapidly start to improve. I'm not saying our life expectancy gets longer. Of course, 65-year-olds have longer life expectancies than 40-year-olds because they live that much longer. I'm saying our ranking, 70-year-olds compared to 70-year-olds in other countries, do increasingly well here once they get access to Medicare. So Medicare has a huge positive impact. So there's that. We're also not a very happy group of campers as physicians, and I'll explain more about why that is to you. Here we are, almost the least happy physicians in the world, and I'll walk through what I think are the reasons and why the solution needs to address those reasons. So first question, of course, is can we afford to do what I'm talking about? I told you that my background, I spent 8 years as a chief medical officer at a Fortune now 50 company. I think a lot about the economics of this. Can we afford to do this? And I'm not here speaking for or against any political candidate, but here's a misrepresentation of some facts for you. This was from, I think, the USA Today not too long ago, and there was a similar piece like this in the Wall Street Journal a week after this, and they're all the time saying that his plan is too expensive, saying his plan would cost us $18 trillion over the next 10 years, and that 15 of the $18 trillion is because of his idea of national health insurance. That's what we're hearing, but we can't, maybe it's a good idea in theory, but the country can't afford it. Well, that's misrepresenting, because here's one of about a dozen analyses of this, and there have been about a dozen economists who've gone through this, and they all come out with, it's at least break even, generally they come out with there's a savings if we do this for the country and for us as individuals. So, it's obviously not a very populated chart, but in this example, you can see that the green box is bigger than the red box. We save more than our new costs. And this analysis comes from Professor Gerald Friedman, the head of economics at the University of Massachusetts. So populating this, He said, first of all, you have to pay more for Medicaid patients, because as you know, we don't pay anywhere near what it costs most physicians to deliver care to Medicaid patients, so you gotta pay more. I shouldn't have to do an assessment of your economic value to me before I let you into my practice. That's not what drove me to go to medical school. I don't want to have to do that. So pay the same for all patients. So Medicaid, that's what it would cost. Covering the uninsured, that's what it would cost in billions. And of course, everybody would start doing stuff because people want more health care. They simply can't afford it because of the financial barriers we've set up. If you eliminate those barriers, they'll go to the dentist, because this plan would cover dentistry. They'd go to get a variety of things that they probably need. So there's a cost to that. This is where the article I just showed you stopped. They just looked at the new costs. And that's misrepresenting, because there are savings. For example, it's cheaper to have the government administer one plan than to have it administer dozens of plans. That's a pretty small savings. That's a pretty small savings. Health insurance administration, the cost of all those people working in the insurance industry, a lot of that would disappear. And you're then immediately worried, well, those are jobs. We don't want to disrupt the economy by hurting the jobs. Understand that those jobs have a 25% annual turnover rate. So no matter what you do today, 2 years from now, half of those people, more than half of those people, won't be in those jobs. And we need those folks to be retrained at other things. So yes, but we could say, look, that is non-productive. It's not helping anybody's health. Administrative cost to providers. Most practices average about $84,000 of administrative folks who do nothing but manage billing and accounts receivable and the insurance product. That's the piece that Dr. Umbehr's plan really addresses. That's nice. So there's that savings that this plan would also largely eliminate. And then lastly, of course, we would enable the government to negotiate the prices of drugs and devices, which would save that much more. So at the end of the day, by this analysis, it's clearly pays for itself to do this. So nationally, we can afford to do it. That's not the issue. And indeed, that's not where the discussion, let's being honest, is at. So that's this analysis. There's a dozen like this, but they all come out with the same answer. You don't have to rely on this sort of an approach. It turns out that there's actually been a real-life experiment comparing our model with another. Canada versus the United States. I'm not saying we should do what Canada is doing, but I'm saying it's pretty close to what we should be doing. So it happens that in 1971, which is when the experiment began, Canada and the United States were having almost the same results from their healthcare systems. We were both spending about 6% of our GDP, of our economy, on healthcare, and following the same trend curves, and I'll show you that in a moment. And our life expectancies were within about a year of each other. And then in 1971, we had a fork in the road, right? Canada put in their national health insurance program, fully implemented it in 1971, and the United States President Richard Nixon signed into law the HMO Act, ostensibly to reduce the cost of health care. So we went down the road of managed care starting in 1971, and they fully implemented their national health insurance program. Well, what happened? Started about the same, diverged. What happened? So, I just talked to you about. So here's our expenses as a percentage of GDP, the relentless curve. You've seen that chart. I'm sure you know we're like near 19% right now. There's what happened in 1971, no real impact that I can tell. You've seen that. Here's Canada's chart, almost the same. And they put in this different program, not like what we did in 1971. And the slope of the curve, it wasn't a price negotiation. That would have just been a drop along the y-axis. It was the slope of the curve that changed. And they've slowed down their rate of growth to a more sustainable level. Today, they spend half of what we spent. They have now less unmet healthcare needs. So we have 14% of Americans who would say we have an unmet healthcare need. There's a much smaller number in Canada. Most of it here is not from waiting lists, because people say they can't afford the cost of care, and then a smattering of other reasons. In Canada, most of it is from their waiting list. So they do have a waiting list issue in Canada, and some from cost, because it's not perfect, and then other reasons. So there is a waiting list issue in Canada. That is not for life-threatening things. It's not for lymphoma and leukemia and heart attacks and such like that. Those folks get in immediately and don't have to go bankrupt. It's for the other kinds of things. And that's a problem. They don't like it, but they know that when they get leukemia, they don't have to have a bake sale. So they think it's the right decision. And they spend half of what we spend. That's why they have the waiting lists. So I'm going to skip this. So at the end of the day, their life expectancy was 1 year longer than ours, and now it's 2.5 to 3 years longer than ours. That's pretty profound if you ask me. So this is time to call off the experiment. Their model worked a lot better than ours. What's it like to practice in Canada compared to here? So here's what the average week for a family medicine physician is like in Canada. And I'll call your attention to that. Family physicians in Canada spend 2.5 hours a week on non-clinical, not medical records, non-clinical administration. I mentioned before that we're not very happy, and I submit to you that that's because of this issue. So it turns out that you can stratify physicians by how happy they are, how satisfied they are with practice, and when they sit by the number of hours per week they spend on non-clinical administration. And when you get over about 8 or 9 hours a week, we become really unhappy because we didn't go to medical school, you didn't go to medical school, you aren't in medical school to do that stuff. And in Canada, remember, that's what they're spending. So income in Canada, physician income in Canada is not ungenerous. This is gross, not net. But there's that. Their incomes are quite competitive. And at the end of the day, American physicians the last 15 years have been migrating to Canada. Canadian physicians have been returning, repatriating. And malpractice is way different in Canada because the future cost of medical care is part of the system there, right? When somebody has a bad outcome, be it something we did or not, they sue because, in large part because they're worried who's going to pay for the future cost of their care. Well, they don't have to worry about that in Canada. So the lawsuit frequency goes down. They're also probably not as litigious as we are, but the reason to sue largely disappears, and the judgment, when they do choose to sue, the largest piece of that today in America is for the future cost of medical care. So that goes away. So at the end of the day, malpractice premiums in Canada are a fraction of what they are here, and we're the only country where you go up and talk, a physician goes and talks to their legislator, and they know, I get it, malpractice. That's the only country where that happens. Other countries, they don't think that. And then overhead, this really plummets, that $84,000 a year I talked about. So I showed you the gross incomes. That's what their overhead does. So huge improvement. At the end of the day, this is a group you should know about. If you don't know about this group, you should. The Institute for Healthcare Improvement. Have you heard of the IHI, Institute for Healthcare Improvement? Good salute. I don't think they answer at other places necessarily, so good for salute. This was Don Berwick's outfit, who was the administrator for CNS for a while, but this was his baby for a long time. And they talk about the triple aim. The triple aim. Any solution should be focused on this, and these are synergistic aims. First of the triple aim is the experience of care, right? So that in part means their relationship with you. It means access to you. It means can they come in to see you. It means can they afford to come see you. It means is the care representative of the diversity in your community? Do you reach out to the people who are low income, who are typically disenfranchised? What is the overall experience of care? And I would submit to you that part of that is addressed under what Dr. Umbehr is talking about, but not all of it. So the experience of care is one of the key goals you want to look at. Secondly, you want to look at the per capita cost, of course, and we just talked about that quite a bit. And then lastly, population health. You need a strategy that actually will improve the health of the total population, not just improve the particular health that an individual doctor is doing, but improves the overall health. Make an alignment of improving health with the demands and rewards of clinical practice, because that's really why you're here. You're here really because you felt called to do something with your brains and your skills and your heart that's going to make people healthier. As much as you can. You want to do as much of it. You want to, if your heart were a cannon, you would torpedo your heart against the whale, as they said in Moby Dick. You want to get in there and do as much as you can to help people as well as you can with all of your skills and talents. And at the end of the day, to say that phrase one more time, that's why we're here. So that's what I want to say to you.
Now we'll have a 3-minute rebuttal from Dr. Josh.
3 minutes. Where to start? The beautiful part about the debate is neither party gets their own facts. You can have your own opinions, but the facts that he stated are grossly over explained and insufficient. And what I love about this is anytime we get in an argument with the Physicians for National Healthcare Policy, it's really just a lesson in the type of logic fallacies that you'll see in any debate. Some of my favorites show up, as always, the incomplete comparison fallacy. Insufficient information is provided to make a complete comparison, and then a conclusion is tried to be pulled from that. Well, because Canada has some things different than us, they're better. Now, the crux of the argument was to prove that a social system, a universal payer, would decrease American costs and improve American quality. But comparing an American system to a Canadian system doesn't explain how a universal system would lower our costs, because we're not Canada. And in fact, I would argue that Canada doesn't want Canadian health care. Excuse my poor French Canadian. It was the Supreme Court case of Kalouy versus Quebec, where they banned, they had a radical restructuring of their health insurance system because it was a moral wrongdoing. In fact, the judges said that the long wait times violated Quebec's Charter of Human Rights for Freedom Act, and even though the time professors said Canadians don't wait long for specialized health care, the truth is the Fraser Institute of Quebec released their yearly study 2 weeks ago. The Canadians wait an average of 18.3 weeks for specialized health care, 18.2 weeks for generalized health care. So actually the data doesn't support your argument. And in fact, a Canadian system that is now banning we're supposed to go in, but I can keep going, and will. The moral high ground. Oh my God, you wonderful, brave young souls, young med students, flush with that, bright-eyed, bushy-tailed. Don't you want to go out and do a moral system? Don't you want to be considered moral and righteous by your peers, to go out and care for all those people in a truly meaningful universal system like Canada has or England has? You could, but then you would be like Nebraska or the NHS, which has over a third of their physicians leaving the system because of burnout. That's funny. I thought a universal system improved physician burnout. Not with all the paperwork and things that they're not doing anymore. Perhaps it's the government control and the limit of care and the dictating of resources that is burning out the NHS doctors, because it surely can't be this euphoric universal healthcare system we've heard so many wonderful things about in the previous 15 minutes. Perhaps it's the shotgun fallacy or the fallacy by Jish, because you've said so many things in so little time that it's hard to argue with each one of them. But my another favorite is the argumentum populum, ad populum, argument to emotional appeal. Again, we're the only backwards industrialized nation to not have universal health care. How dare we? We should be embarrassed. When we go to prom, all the other nations will be looking at us like we're so weird. Yet somehow we create more innovation in our healthcare sector because that's part of our healthcare cost. We're investing money in research and medications. But Canada has cheaper medicines because the government pays the pharmaceutical companies $2 billion a year to subsidize the cost of their insurance and their medications. And we often benefit that from when those medicines come across state lines. So fast 3 minutes. I look forward to the rest of the day.
Thank you, Dr. Dash.
Yes, sir.
We will now give Dr. Weisbart a 2-minute response.
Thanks.
It would be a debate if we didn't go further.
As I said, we actually agree on a lot of stuff, but we're not going to talk about any of that. Just about something.
What is that?
So the United States versus Canada. Why would I pick Canada in comparison? Because it's the closest country, but you could pick almost any other country in the world. And in almost every other country in the world that does this, the results are so much better than ours are. I just can't believe it. This is the only key. It's almost every other country. It's not just Canada. Almost every other country, the costs are lower. Why are our costs so high? Our costs are so high for 2 reasons. They're because of prices. We don't do anything about prices here. And they're because of the complexity of how we've set this up. If you fix those 2 problems, that's how. So yes, today we have perverse incentives. Today, hospitals are rewarded for reducing their nursing staff so that they can increase their latest imaging device, right? So there's pretty tight nursing staff and there's pretty robust high technology because they were competing to try to get people to use this technology and be attracted to their institution. They're not evil, that's just a fiduciary game of how they have to stay in business. So eliminate that whole drive. Have a budget for the region that then can be aligned with the health imperatives that are going on. Innovation. I love our innovation. Where does most of our innovation come from? 90% of the research on new drugs and such are funded by Pfizer, funded by Amgen. No, it's funded by the National Institutes for Health. Most of the groundbreaking research is funded by you and me. It's funded by our tax dollars today. So I'm not too worried that we're going to lose that innovation. And most of the innovation, frankly, that we see coming out of the pharmaceutical manufacturers, some of it's spectacular. There's some great new things, but most of it is to try to find that little market niche for a new use for paroxetine for something, a 7.5 milligram of something that doesn't have a generic version versus a 10. Most of their research, a large chunk of their research, is not to advance the public health, it's to do this. And I know we produce an awful lot of medical literature, and that's terrific, but if you look at the groundbreaking research articles we produce per capita, We are middle of the pack on world norms. A lot of the major breakthroughs that you can think of that I can't really rattle off, I'm not done. A lot of the major breakthroughs you could probably think of didn't happen here. We wish they did, but they didn't. We have a lot here too, but if you correct that for the size of our population, we've been falling behind because we've been letting these perverse incentives take over where our innovation and research focuses on. We can do better.
Thank you, Dr. Weisbart. We will now go to Dr. Josh to give his argument against the resolution.
I have a first name too, but I'm not telling anybody who is.
So let's not overskip the point that he just told you to assume that most of the innovation doesn't come from here, but gave you no facts to support that. And you're supposed to take that and believe that and change your entire system of healthcare. So what we keep doing is this argument, this fallacy, that logic fallacy, where we can talk about lots of other things that don't actually impact the debate question. And the debate question is how to lower costs and improve quality. So for the people who were in the new conference with me today, you heard about our model. And so to continue with the debate, it's important to frame what we do. We started 5.5 years ago. We're an insurance-free family practice. We charge $10 for kids, $50 per patient per month for unlimited home visits, work visits, office visits, technology visits like email, cell phone, texting, Skype, no copays. Any procedure we do in the office is included free of charge. Stitches, biopsies, joint checks, stents, ultrasounds, rapid strapture analysis, cryotherapy, lesion removal, minor surgical procedures, all free. It cost me 36 cents to do an EKG. Literally the coffee in my K-cup in the waiting room costs more than the EKG. So I can absorb that cost for my patients. Then we move forward, and unlike someone who worked at one of the most expensive ways to get medications in the country, Express Scripts, we actually work for our patients to decrease the cost of medicines by up to 95%. 44 states allow physicians to dispense medications to their patients like the pharmacy. Kansas, where I'm from, is one of them. So I can get medications from the same places a pharmacy does, but based on our free market approach, we don't have to make any revenue off the membership. It is a value add to incentivize people to pay the membership and be a part of our practice. So Imitrex, that might be anywhere from $80 to $256 cash price at the pharmacy, I get for $5. My patients get for $5.50. We mark everything up 10%. And capitalism. I got 10 cents in the bottle, 3 cents in the label. We cover our costs. So we do the same thing with labs, imaging, pathology, specialty care. Most things that we can get DME, we can decrease 80 to 90% for our patients. We can take that value and go back to employers, not individuals, because the Affordable Care Act, decrease their insurance premiums by 30 to 60% year one. So right there, I've shown you already how a free market system answers the question that the debate is being posed on. How do we decrease American healthcare costs and improve quality? Well, right there, unlimited visits, no copays, and free procedures sure helps improve the quality of healthcare delivered by any physician. And the opportunity to improve healthcare. When I can get a CBC for $1.69, which includes my 10% markup, damn capitalism, versus $50 for an insurance-based system, an A1C $2.26, a lipid panel under $3. I'm doing more real-time without government interaction to decrease the cost of care. If you believe that Medicare has an efficiency of 1.3%, I have a bridge in Arizona I'd like to sell you. It doesn't exist. And I'll let you go out and find the data because that is old, inaccurate, and dishonest arguments that the physicians for national health care policy continue to trump. They'll also continue to trump other facts like infant mortality. Infant mortality is one of the worst studies ever done if you actually look at the results and how they did it. The U.S. is one of only a few countries that actually strictly follows the WHO's definition of what is it, a stillborn birth, and that's any baby that comes out with any sign of life. Most other industrialized nations, Britain and France included, consider it to not be a stillborn life if it dies after within the first 48 hours. 90% of babies who do die within that first period, so they've already played with their numbers. So you can't take an otherwise unrelated fact. Yeah, we might have more mortality. If we did, that doesn't mean our system at whole is wrong. That's a fallacy. You're trying to throw the baby out with the bathwater. That could say one piece of it's bad. But it's not bad. It's bad data. If you want to say medical bankruptcies are wrong, like he tried to say too, that data was so poorly done, other journals published reviews of that because they were embarrassed by that. The authors of that study went to 5 of the over 1,500 different bankruptcy courts and studied 1,700 of the 1 to 2 million bankruptcy claims made per year. They said that 58% of bankruptcies had a medical expense related to it. The actual data, when re-reported by honest reporters, was 17%. So it was $2,000 was the average amount of money that caused a medical bankruptcy. And I agree with that fact. He said most Americans can't find a $3,000 cash to pay off their premiums, their deductible. Perhaps that's because their premiums are so high. Perhaps that's because the market hasn't been allowed to come in because government regulations said you must cover all of these things, and that adds a substantial cost to your premiums. In our model, where we help our employers get full scope, unlimited outpatient care through our clinic and decrease the cost of their insurance to around $100 per member per month. Well, maybe now, when you save $6,000 per person per year, you'd have the $3,000 to pay off your $3,000 deductible. But let's put that into context. How many people need their $3,000 deductible in a given year? 87%, according to insurance companies' own numbers, of people will not reach their $3,000 deductible in a given year. Even Malcolm Gladwell, prolific author of Business and all related topics, has now come out and said we have too much health insurance. If I tried to give you car insurance that covered gasoline, you wouldn't even buy it from me because you'd see how ridiculous that would be. Gas is cheap, oil is cheap, windshield wiper fluid is cheap. So we make this false assumption that healthcare is expensive, and the only way to pay for that is for those glorious people at the government to hand that down to us. But there is another way. Silicon Valley doesn't get out of bed in the morning unless there's a 10x improvement. But Elon Musk can send a package to the space station for 5% of the cost of NASA. Why? Because the free market tends to fund waste and efficiency and turn it into profit. So they can do more for less than the government-based system can. We can do the same thing in healthcare. So if all we want to do in this debate is prove that a system other than universal healthcare will lower costs and improve quality, we've yet to hear anything other than comparisons to other countries, false analogies. Doctors are happier under Medicaid, yet somehow leaving the NHS in droves. Medicaid, in most states, have worse healthcare outcomes than the uninsured because doctors won't see Medicaid patients because they lose money on them. And as altruistic as you want to be as a med student, when you come out and you lose money on those patients, you understandably decrease the amount of care you provide to them. But we have a way to take care of people. It is the free market. We have a way to feed the hungry, and that's through a cash-based system that doesn't have paperwork, that doesn't have regulation, that does have some government involvement because poor people tend not to have money. Right? We get that. That's the issue. So if we can give them money to buy health care that's already driven down by 95%, their dollars will go that much farther. So it works for those on the left of the government that want more care for more people, a laudable goal. And it works well for those on the right who say, well, we only have so much money, we need to be fiscally responsive with our resources. Great. So the government can act as a purchaser in this process too, but most of the time they can't be dictator of the policy. They can't say one system to rule them all. iPhones are great, but they don't have 100% penetration of the market. And I would be upset if Google owned 100% of any market. I'd probably begrudgingly go to Bing. No one player in a free market system controls too much. And if they do, the government shuts them down. But monopolies are okay when you're the government. We said so. But look at schools. They're increasing cost and tax revenue every year. In Kansas, we've gone a 3-fold increase in what we spend per kid on administrators, but not on teachers. So we spend more and more in a system and get fewer results. Post office has talked about closing Saturday hours because they can't even deliver the mail efficiently. And we want to give them something as complex as the healthcare system. Health insurance premiums are supposed to go down by $2,500 according to the Affordable Care Act. They've gone up by double digits. No one has even expecting health insurance premiums to go down, just maybe not go up as much. It's a victory if they only go up 20%. We've decreased the cost in real time of health insurance. That's putting money in the back of people's pockets. That's putting jobs back where they weren't because the cost of health insurance was rising. That's empowering physicians to take care of their patients in a way they haven't been able to in a long time. cutting through the red tape and the bureaucracy and getting down to brass taxes so that your medicines can be pennies a pill for a patient. I get 1,000 Lasix for $8. I've been to Walmart. I've told their executives, we got Walmart at Walmart. Good competition will drive the cost of that down. And the reason we don't have a better system is more physicians are being forced to swallow the moral fallacy of you're not a good caring clinician if you don't want a universal healthcare system. I rejected that in med school, and you should too. I say if you take your oath seriously of do no harm, that has to include do no financial harm. You have to ask yourself, how do I go out and find a system that actually lowers the cost of care for my patients and gives them freedom? The government can lower costs whenever it wants by saying we won't pay for something. That's what happens in the NHS when breast cancer medicines come over, but they say, no, we don't have it in the budget, so we don't allow it. So what happens in Canada when they need a surgery? They don't want to wait 18.2 weeks. Or in Canada when they actually sue the government because the care was delayed so long, and the government agreed with them that it was a violation of their human rights to wait that long for health care. Well, they come here, where you can buy a hip surgery for $19,900. You can go check it at Surgery Center of Oklahoma. They have their prices on the website. In fact, they're so cheap that now insurance will pay patients up to $20,000 to go there instead of go to surgery centers in Boston because Boston's hiked up the price. That's fine, that's free market. Boston can do it at once. But patients can do what they want too, and they can travel for highly cost-effective care and save a buck. You can't do that in a universal system where there's one Lord and one master. So I think you really have to ask yourself, what is the most free market? What is the most free system for you and your patients? How would you willingly lead your patients down a path to a system that there's only one ruler? The government decides what kind of care you get, and that's it. That's probably why those doctors are leaving the NHS in drugs. They're underpaid, overworked, and overregulated. And so if you look at a system that gives you the best opportunity to take care of your patients, because each one of you are going to do that difference, versus the DMV.
So I have the pleasure of going to Jefferson City every once in a while and meeting our legislators, and I met this one, Casey Mersey, who actually submitted a bill that said that we wanted to make it illegal for the federal government to send drones into Missouri because he was convinced that President Obama, and he said this, I was closer than I am to Josh right now. He said this to me. He said because he was convinced that President Obama was going to send drones into Missouri to attack anybody who didn't sign up for Obamacare. Honestly, he said that to me. So, I think we can be a little bit overly, wait, this is my 2 minutes here, sir.
My clause was up, I just leaned back and paused. But no, you're fine, I was more or less done. But I'll take that argument to see exactly, when confronted with facts and data, he insults. He doesn't want you to listen to that. He wants you to assume that if you believe what I believe, that somehow you too are a tinfoil hat, drone-fearing, Obama-hating person. You can't be a good clinician who gets good grades and does that. So it is another logic fallacy that instead of arguing the facts and the data, he insults your intelligence and mine with a comparison like that.
Are you leaning back or are you done?
I'm leaning back.
Oh, I'm sorry. Were you both? Okay.
Yes.
Sorry. Okay, so the 1.4% overhead for Medicare was from that crazy group called the Medicare Trust Fund. It's the group that's reviewed by the Congressional Budget Office. It's a group that reports to Congress. So that's where that data source came from.
And we trust everything the government says.
Yeah. I have a cat here for you, sir.
Yeah.
The infant mortality data, we actually agree about that. And you notice that I didn't quote that. I believe there's an issue with the definition of terms of that.
But the Physician for National Healthcare Policy still does one.
First of all, called the Physicians for a National Health Program. And yeah, I mean, it is the published data, but let me go on.
But you can't have a moral,
I didn't propose any moral background. I proposed a solution. Let me tell you one of my biggest concerns with what you're proposing. Since we're having a dialogue.
Sure.
So how many?
To that effect, the dialogue, sorry, just to stick with all due respect, just to stick with the time, we'll have time for discussion at the end, but you do have a 3-minute rebuttal that you're kind of in the middle of, I think.
My rebuttal includes, I understand that his practice, the TPC model in general, limits the size of the practice to about 500 patients in general. According to the American College of Physicians, There's many practices that are actually smaller than that. There's some that go a little bit higher. But when most of them hit a few hundred patients, they then close their practice and often go out and hire a second physician to come into their practice. That's lovely, and oh my God, that would be a great life. And I can completely understand that. And the idea of having 500, 600 patients in my practice, instead of the 4,000 that I had most of my career, or the 2,700 plus that most physicians actually have on average, it's a much better lifestyle. You don't have to work the 60 hours a week that I was working when I was in full-time practice for 20 years. I get it. And it's comfortable. It's more fun. You can do these other things that physicians are so good at. We're so good at negotiating, right? So just think of that. Let's say 600 patients compared to 2,700 on average for physicians. If everybody in the country made that shift, we would need, let me do the math, 4 times as many doctors as we have today. So if everybody in this room and everybody in medical school around the country says, yeah, you know, that's what I want to do. I don't care about those other issues. I just want to have a little more happy lifestyle, I guess. We would have to have 4 times as many doctors, or we wouldn't have any doctors to take care of. What do you do if you're the doctor in town and your colleague decides to do that? You then have to absorb the other 2,000 patients. And so you negotiate a lower price for employers. I think I heard that said, that it goes into employers and negotiates that they can pay less on their insurance and the premiums go down. How do they do that? What's the premium design? What's the healthcare benefit design that the employer shifts to when they start adopting perhaps funding in part or in full or direct into a DPC practice? What do? They switch to a catastrophic benefit design. That's what they do. They say, we'll use the DPC for all the primary care. Josh will negotiate for all your specialty and imaging care and your drugs and all of that. And then when you have a catastrophe, if you get above 6,000, that's the part that we will kick in on. And as a result of that, if we did this as a national health policy, and as a result of that, we'd have people, the bankruptcy problem, 16%, I'm not going to argue sources and facts with you, and I'm not, but 16%, whatever it is, that problem is going to get worse if we do this. If everybody, and people have been proven to not be able to discriminate between which things they should and shouldn't be spending their precious dollars on. They don't just not take their Nasonex, they don't take their insulin when they have a high deductible. They don't take a lot of things, and granted, maybe you can negotiate some of these, but with every doctor in the country, I've negotiated for thousands of physicians, or hundreds of physicians over the years, and most physicians are not good negotiators. Maybe you are, but most physicians don't have those skills, don't have that interest, don't have the business acumen, don't do that. And to think that every physician is going to get every other specialist to drop their prices at that rate, that's not an organized national health solution. That's not a solution to any of our crises. It makes for a better lifestyle for docs. It makes for the patients who go to those practices are probably happier because of all the reasons. I'm completely buying that. But, you know, and the American College of Physicians last month came out with a report showing that most of these practices have lower penetration of African Americans, lower penetration of Hispanics, have lower populations of diabetes. We don't know why. Is it because those populations can't afford and don't choose a retainer? Or is it because people setting up that practice know they want to get into a wealthier community that has less of those risk factors? If you're taking a monthly payment, you are running your own HMO. You are running your own HMO. And maybe you're not going to do this, but the dynamic, the incentive that you have then set up is to attract the healthy and shun the sick. I'm going to open a DPC practice on the second floor of a building and put in a gym there so that the healthy patients who want to use a gym and can go up to the second floor will come to my practice. And I'll have 500 or 600 patients who are pretty healthy and are paying me for when they get a problem that's within the range of my scope of practice. But the rest of you folks who have really bad diabetes and want to come in 3 times a month, or I want you to come in 3 times a month, if I tell you to come in 3 times a month, I'm telling you that I'm going to absorb the cost into my practice. And maybe you would do that, but you wouldn't do that for all your patients. And if that were all your patients, you'd go out of business. So this model is a perverse incentive that erodes the patient relationship.
Thank you. We'll now give Dr. Josh 2 minutes.
This is my favorite fallacy of all. Logic fallacy. If you can't blind them with brilliance, baffle them with bullshit. And that's what we're seeing here.
I agree.
Well played. So, The ACP, the American College of Physicians, did do a report. They ignored all the available research. In fact, the same day they released their report, the AFP released their summary of all the research on DPC, and ACP said there was no research. Every DPC doctor doing this and doing the research came out violently against the ACP's inaccurate and poorly researched study. He says 500, then he says a few hundred. We do 600 to 800 patients per clinic. But the fallacy, how dare you? How dare you be free and do a practice you want to be happy? That doesn't make a good physician or a national health care policy, does it? So you should be unhappy and take care of too many patients who work 60 hours a week, burning yourself down to the ground, because that's clearly resulting in good physician burnout levels, right? I mean, that's working currently. That's the ship we're on. The taking care of too many patients and burning out and having fewer doctors. So this fallacy again, that there's a physician shortage. We say these things, you hear them, you repeat them, you're good med students, thank you, but they're not true. They say there's a physician shortage of 50 to 135,000 family physicians by 2025. But the AFP does a study that says 22% of a doctor's time is spent doing non-clinical paperwork. Yeah, it's higher than that. But for 22% of the time, multiplied across the physician workforce is the equivalent of 165,000 doctors. So we have plenty of doctors in the workforce. We have an efficiency issue that gets better with free market. And again, the fallacy, the insulting fallacy here is how dare you look like me and take care of only 600 patients. Of course, when you're an administrator of a giant Fortune 50 company, okay, you don't take care of any patients in that model, do you? Okay. So it's okay to be an administrator. That's completely morally, ethically fine. It's a profession, good, upstanding doctor, as you all are. But hey, if you take care of 600 patients, you're a capitalist pig. So my 600 patients are just rich, healthy people. I'm a bastard. I won't take care of anyone poor, black, female, anything, or sick, heaven forbid. Because I didn't go to med school to take care of sick people. Stay away from them. No, this model does work best for poor people and sick people. You save a rich person $100, they're happy, but it doesn't change their life. You save a single mom working a $10 an hour job at a call center, $100 a month on her Imitrex, now her quality of life is better, and her employment opportunities are better because her migraines are better controlled. You change her life. You change her kid's life. You allow her to call, text, email you for no copay. She doesn't have to leave work. She has to ask for permission to go to the bathroom, let alone go to the doctor. So you change her life in a way that a socialized, single-payer system won't currently allow. So listen to what he says and tries to insist upon you how you should think about the model. Look out and research the model yourself and see how it really works.
Thank you, Dr. Josh. So now for the next 15 minutes, I am going to pose some questions. They may be directed to both of you, they may be directed to one of you. You'll have 3 minutes to respond, and then if necessary, we can have a 2-minute rebuttal. So the first question is directed to Dr. Weisbart. With Medicare as a single payer for all Americans, healthcare, some have brought up the issue of fraud, abuse, and waste within the system. There are some studies that have shown that it could be anywhere from 5 to up to 10% of all Medicare revenues go towards fraud, abuse, and waste within the system, which would be tens of billions of dollars. How would single-payer Medicare fix that problem?
Sure, that's critical. There is a problem. There are problems with Medicare. That's one of the problems. There are others. That is one of the problems. And that's why I think the 1.4 or whatever the number is percent of overhead that they have is probably not enough. I think they need another chunk of cash. I don't know how much, but another percentage or something to do more aggressive fraud, waste, and abuse work. I don't argue against that concept at all. So there is that. But understand too that fraud, waste, and abuse are not unique to a public system. They're in all the private systems as well. So, and indeed, in past lives and in the insurance industry, we discovered that, and we built an extra system that cost an extra amount of change, and we eliminated more of it. So, but that costs some money. So that would add something to the overhead of Medicare, and I don't think there's really any disagreement that that would be a good thing to do. The key too is that you eliminate the perverse incentives that drive people to want to do this so much.
Thank you. Do you have a rebuttal, Dr. Josh?
if the estimated abuse and fraud is almost 8 times higher than the budget, and the budget is already 14% of our national budget, how much more money are we going to give to a system that's clearly inept? They're not spending the money wisely. They're not good stewards of the money. They're taking money out of the system that could be better spent by somebody more productively, and I still reject the fallacy that the budget's only 1.4%. Multiple articles have debated this and found that that's clearly a short-sighted view of the budget, but we wouldn't give that much money to a system already swimming in inequity.
Thank you. My next question is directed towards both of you. So we have our current system, half of which is paid for by Medicare. We have a lot of problems with disparities, which you both have touched on previous to this question, of getting access to care for the poor, different races, women, all sorts of different groups. How do your proposed plans address those issues? Our current system, if we expand to Medicare, we need a plan for addressing disparities. And with a direct care model, we also need a plan for addressing disparities. I'll let Dr. Josh go first.
So, Milton Friedman, Nobel-winning prize and economist, said that the problem with poverty is that they're poor, right? You don't have the money. It's not that they're lacking a government system to take care of their house, their clothes, their internet, the individual system. We have a way to help people who need resources. And the government does have a role. I'm not an anarchist. But it's a role that should be done as efficiently as possible. Expanding Medicare, expanding Medicaid, this has already been proven to be bankrupting states. So it's not working in its current form, so we just keep doing more of it? No. We've come step back and find an intelligent system that will get those end results. More people are being denied care because of a Medicare system that doesn't reimburse physicians well to take care of them, or a Medicaid system that physicians actually lose money on. These patients aren't valuable to doctors, they're painful to doctors. If you had a practice of only Medicare and Medicaid patients, you couldn't keep your doors open, the revenue. So if we step back and said, how do we feed poor people? We have a way, food stamps. It may not be the best system, but it's a very efficient system. Now those people are just like any other person. They have dollars and they can vote with those dollars, and they can go to any participating store and spend those dollars. And they can find the best way to spend their dollars for them. Now, granted, he said you're not smart enough to spend your dollars. That's already been proven. So maybe we shouldn't let this group do it, but surely another educated group can find a way. People can figure out how to spend their own dollars. So we can put checks and balances in there for them. So if we gave them $50 a month to go out and shop for the best health care they could get, wouldn't that be better than a system of Medicaid where doctors refuse to see them because they lose money on them? Make these people valuable to the economic system, and it will drive better care. Doctors will compete for those dollars. We've done the budget analysis for my state, Kansas. We have a $3.2 billion system for 400,000 Medicaid recipients, and they're losing $1 million a day. We could do a direct care doctor at $60 a month per person, pay for private Blue Cross insurance, pay the premiums and the deductibles and the medicines, and it would only cost $1.3 billion for the whole system. The free market does find cheaper solutions. Government-based systems typically don't. And I won't say that free market's working everywhere it's tried. Just like government, it can be done poorly or it can be done well. And right now we have a system so gridlocked with paperwork that most free market systems are still struggling. But like our system and systems we recommend, Surgery Center of Oklahoma and other very efficient, streamlined processes, they get great care on the dollar. And back to my other statement, isn't that what we want? Isn't that what the left and the right want? More care for more people, but in a cost-effective way. So I think direct care would actually incentivize doctors to take care of the poor, the disabled, the sick, because they're worth something to them. And it's not a losing proposition.
Thank you, Dr. Josh. Dr. Weisbart?
So a big part of the disparities we have in healthcare has to do with people's unequal access to physicians, which is being driven by people's unequal access to insurance. So if you go 1 mile north of here, 2 miles north, you go 1 mile north of Washington, you come into an area that has the highest mortality rate, I believe, in the state, and one of the highest mortality rates in the country. 1 mile away from Washington, maybe 2 miles away from here, Why would that be? It's because there are very few, there's a lot of reasons, but one of them is that there are very few clinics and physicians in those regions, because you can't make a business model off of putting on the clinic in there. We tried the experiment for 2 years of saying, let's pay Medicaid at commercial rates, 2013 and 14, I think it was, but nobody followed that, because why would you put a new business in for a short-term model? Clearly, to deal with this, short-term, Medicaid needs to be expanded and to be reimbursing physicians at commercial insurance rates. That's how you get physicians to see more Medicaid patients. The disparities in healthcare outcomes are because we, as retail business people, need to assess your economic value as a patient before you can come in. So we set up our practices in places that can maximize that and optimize that. And we don't set them up in the poorest neighborhoods. We need to eliminate that, make every patient in the country worth just as much financially to a physician, should they choose to practice. And we'll find a lot of disparities go away. Some of the racial disparities in mortality for African Americans after heart attacks almost disappear when you control for their insurance status. It's remarkable about that. Medicaid is not bankrupting states. As a matter of fact, in Missouri, I don't know Kansas, I grant you that, but in Missouri, for example, in order to not take the positive revenue to the Missouri budget, according to the Missouri Budget Director, Linda Luebering, if we didn't do the because we didn't do the Medicaid expansion, we had to cut expansions of higher education and of all kinds of other important programs that we wanted to do. Medicaid expansion was net favorable to the Missouri budget and will be when we do that, even in the out years when the state has to pay 10% after 2022, I think it is. So, no, it's not bankrupt. That's the fire on the table more than any of these issues before us. Free market is great for some things. My wife and I ran a retail business for 10 years in Chicago. I'm all about the free market for many things. The free market to me in healthcare means that I want to be able to pick any doctor, and that's not, this is one way to achieve that. A free market doesn't apply to some things. It doesn't apply to insurance when we all need the same insurance. We all have families where somebody needs maternity care, where somebody needs child care. We all are nobody gets out alive. We're all gonna need robust care. Everybody needs, at some point in their life, the same kinds of access to health care. Imagine if we applied the free market to the fire department and made the fire department go door to door negotiating how much you're gonna pay me per year. How many ladders should I send to you? We'd be spending a huge amount of time marketing and negotiating those rates. No, there are some things that the free market really doesn't help with, because nobody thinks they're gonna have a fire. Nobody thinks they're gonna have a heart attack. So that's something that we do need a good system to deal with, and that's the same in healthcare.
Thank you, Dr. Weisbart. Dr. Josh has a rebuttal. 2 minutes.
So again, we love to present an example where I can tell you and expect you to believe that the free market won't work in something. And because it hasn't worked in a disimpoverished area, it can't work anywhere. Back to classic nirvana principle or fallacy. If I haven't fixed everything everywhere, we haven't fixed anything. Or this idea, well, fire, police, you can't negotiate that when your house is burning. No, because like a good citizen, I negotiate that ahead of time. Or whoever's responsible for that, because there's multiple examples of privatized police, ambulances, and fire, and usually it's paid through a different network. Insurance says, if I'm insuring your home, I want an affordable fire network. You know what? When they're not government employees, they don't sit at the fire station. They do go door to door, but looking for sources of fires that are common. Barbecues placed too close to the home, and dry wood placed against the house. Gasoline tanks that are left in the garage, and they decrease fire percentage by 90%. So the free market even works there. Just because he hasn't tried it for fire doesn't mean it doesn't work, but it's really easy if I can just tell you it doesn't work and get you to believe that easily.
Dr.
Another
Weisbart.
point about personalities. That's good.
It wasn't a debate about personalities.
No, I agree, that's good.
Yeah.
Do you have a rebuttal, Dr. Weisbart?
I thought that was the goal of me.
You also get a 2-minute rebuttal, if you wish to take it. That's fine. So I'd like to move questions and comments to the audience. Yes.
Okay, 1.4% overhead in Medicare, that's because that's what they're counting up in deep Washington, Baltimore. Medicare overhead is in my practice and in the hospital. Okay, you all you young physicians, you want to decide who wins this debate as you go through your training. And when you go through the training, if you do it with a believe but disbelieve, okay, When you see something that doesn't make sense, it doesn't work, why do they do it this way? Why is it so frustrating? What's all this paper? What's this computer? You know, that's cost, and that's government cost. It's also commercial health plan cost, especially since they became giant national health plans. Okay? So that's where the overhead, Medicare only counts to the bureaucrats. So the 1 point, the rest of the overhead in my office, the 325 ridiculous quality measures, fake quality measures. A few of them are valuable. An A1C, you know, measure my diabetics against the good doctor's diabetics. Whose A1C panel is less? And you really got to risk adjust and education adjust. So there's few, but when the government gets at it, there's so thick. So I practice in a context that I know that my cost of care of Medicare patients is 50 to 30 to 40% less than the national average. Take great care of it. Okay? Because this context allows me to cut through some of that bureaucracy. It allows me to get to the heart of the matter here. Okay, the center of the healthcare universe is the patient. And in the first orbit around the patient is the doctor, and especially the interns and family physicians. And they're great allies, specialists. Right? And the more stuff you put between those two, the worse it gets. Okay? And we need some economic tension in between those two. Economic tension, because the buyer and the seller, you all buy and sell all day, and you don't go buy them. You know, you're shopping wisely. That's healthy in healthcare. First, do no harm. Be careful for what you wish, what you ask for. So as you go through your training, focus on the patient, see what it takes to get them healthy, and look for the junk in between, and that'll help you decide what kind of system you ought to have.
Thank you.
If you could react to that, sir.
Sure, I agree. The best way to eliminate bureaucracy is to eliminate the hundreds of insurance plans that we all have to deal with. A typical physician has 25 to 30 different insurance plans, and then those have different permutations themselves. It's overwhelming, it's confusing, it's a different form for everything. And you're right, it's not adding any value to the healthcare system. In other countries that have done this, they have streamlined that process so that none of that exists. They have a tiny fraction. Their idea of submitting a claim takes, I've seen videos of it where it takes literally 13 seconds to submit a claim. And then they see the patient, they input the data, which takes, in this one that I saw, 13 seconds. And 2 weeks later, the check is deposited in their box with over a 98% payment rate. Physicians in Missouri have over $200,000 average accounts receivable that's over a year old. So a system can indeed be designed that eliminates most of that stuff. And for most people, that works really well. Most countries, are you saying that we're not smart enough to figure out how to do that? I think America is really good at innovating and developing, figuring out how to do that sort of thing. And I have the confidence that we can do this. We can make this work well.
I think the people in the room are smart enough. I think doctors in the trench are smart enough. But I don't think it's smart enough for bureaucrats 1,500 miles away who aren't in the room face to face with me and the patient. We are smart. The bureaucrats are not.
I guess I kind of wonder, if it only takes 13 seconds to submit a claim, why is it an 18.3-week wait in Canada to see a specialist? I don't know. I guess maybe the universal healthcare system is not that efficient. I have zero insurances. I have 0 times submitting claims. And so if we agreed that submitting claims and insurance adds no efficiency, then why have them? It would be just as ridiculous to submit a claim every time you fill up for gasoline, change your oil type, check your air pressure. It makes no sense. Don't do it. Never do the work efficiently that shouldn't be done at all. It's wasting time, dollars, and resources. So even a universal system that paid for catastrophic care would be vastly superior than a universal system that wants to control every process that's happening in interaction. That's not necessary. We don't need the government there if LASIK is 0.8 cents a pill. Literally anything the government does on top of that adds expense.
The reason we can't do what you're saying is my mother-in-law in Florida had a primary care physician for, I think, 12 years or so, and he decided to go into a concierge practice and charge, I think the same as you, $600, no, not the same as you. He was charging $600 a year for her. She's in Medicare. She lives on about $20,000 a year. She couldn't afford that. So she had to find a new primary care physician.
Sure. What did your patients do when you left medicine?
Because I retired.
Yeah. Oh, it's a moral right to retire and go work for a Fortune 50 company. I'm sure you don't need to share the salary. I won't ask.
I thought you were a capitalist.
I am a capitalist, but you are representing that it's shameful for us to do something different, but it's your salary for a Fortune 50 company, but all of you don't have the individual will to decide what you do with your practice.
You're clearly choosing to miss my point. It's not that you have the right to do
Yeah, it's a
that.
circular argument. Neither one of us can listen.
I'm going to stop the circle and allow another question. Sorry. You had a question, ma'am.
My question, Dr. Johnson, is, so now you are, it's a concierge service is basically taking care of primary care, but people still need to get insurance for hospitalization, right? Do you see any patients in the hospital?
Well, we have social privileges. It's not efficient for our time. We use the hospitals like those times.
So I mean, so basically, what you're doing is just taking care of primary care and then leaving the burden of the rest of some health insurance.
Oh, that's equivalent to saying I leave the burden of cancer care to the oncologist. No, I take care of my piece. And you try to assert that if I don't take care of all pieces, I haven't fixed what I fixed. I've still made a system of unlimited visits, no co-pays, free procedures, wholesale meds, labs, imaging, pathology, 95% cheaper. So the 5% of people who will wind up in the hospital in a given year, yeah, I can't take care of all of them. And I still do recommend they have insurance. That's why I say we go back to their employer and help them, because of our design, show them how they can decrease their premiums by 30 to 60%, to have a $3,000 copay and a $0 deductible after that for hospitalizations. So they're covered better than the Affordable Care Act plans.
But you're still not, okay, but the majority of people going bankrupt is not because they've seen their primary care physician.
You don't know
The
that.
majority of bankruptcies are because we have the health insurance, because people.
The
get
average
hospitalized. And
medical
health
fee
insurance
for a bankruptcy was $2,000. You tell me what hospitalization costs $2,000. You can't walk in and out of the ER for $2,000.
Of course not.
So, right, so then it's not hospitalization as the major cause of bankruptcy. Because for most people, and you can go back, the studies are there. The first study was horribly flawed, the second studies walk through all the broken evidence. So it's $2,000 and 17% of bankruptcies. But that doesn't still imply that my system is wrong. Yes, we fix whatever we can, and it behooves each one of you to fix what you can, just like the Surgery Center of Oklahoma fixes what they can, or there's a cash-only orthopedic surgery center in Rochester, New York, that does what they can. Each one of us fixes a part of the healthcare system to maximize the value and cost for our patients. That is our moral goal. That is the justification of the system, is take the best care of our patients at the best price. And I can't do everything for my patients, but that doesn't change what we've done for them so far.
Thank you, Dr. Josh. Any other questions or comments? Yes, sir.
So I went into medicine with no intention to work for the government ever, but now under a national health insurance program where all my paychecks are coming solely from the government, would I not just be another government employee?
Well, actually, yes and no. And I, too, don't want to work for the government. There are many different ways to set this up. The way that Great Britain does this is indeed what you're describing. That's truly socialized medicine. Socialism is the government owning the means of production. And that's what we do for the VA. That's what they do in Great Britain. That's not what I'm proposing. That's not what I would want to do. I've never wanted to work for the government either, personally. There's a different, more conservative model that just deals with the financing side. Just pulls the insurance piece out of it. You would still be working directly for your patients. You would still be working directly for your patients. That's the relationship. You would be responsible for your own P&L. You'd be responsible for your own practice. You would choose what kind of a practice setting you want to go into. It just happens that you wouldn't have to deal with 25 different insurance companies and all the different flavors of that. And you wouldn't have to deal with patients saying, gee, I'd like to see it, but I can't afford this retainer. So you would be in control of it.
You would just not be in control of what the dictator says. You can choose whatever you want, but the government is ultimately the one saying, we will or won't pay you for this. And thankfully, we've streamlined that process. You don't have to ask 25 different insurance companies. Won't tell you right away. It's an 18.3 week wait for specialist care in Canada because they limit how much care the specialist can do. That's how they can do it.
Yes, sir.
Yes, I'm 65, 67, I'm in Medicare. And my understanding of this, correct me if I'm wrong, Dr. Josh, is that I don't know too many people that want to give up their Medicare.
They don't have to.
Didn't you listen to me? I don't think, I know of anybody that wants to give up their Medicare, just the opposite. And all I'm hearing is fix the broken pieces of Medicare and give it to everybody from birth to death. And the government pays for it. That's all this is about. They don't own the doctor, they don't own the hospitals. They just Medicare for everybody, which everybody loves. Why not give it to everybody from birth to death? Don't give me any free market stuff on this, because I won't listen to it. You've been lying on a lot of stuff there, because I could document it, but I'm not going to do it. But just saying from what answered the question I gave.
I would say that most patients don't like their Medicare. That's like saying all Canadians love their
I didn't say
healthcare
all,
system.
I said most patients
Well,
do.
I-
Where's the study that says the opposite?
So, look, it's the.
Where's the study that says the opposite?
You'll have to let me finish. This isn't your debate.
Answer my question.
I am trying to. But I won't let them behave like that.
Oh, sorry, Josh.
Yeah, it's okay.
We're going to let Dr. Josh answer.
Now, dementia is rough, folks. It can be hard to watch in action. So,
You don't need to get
well, he doesn't either. So the fact is, not all patients like their Medicare. The fact is, Medicare patients have a choice to choose what they do and where they go. And I don't have to present the idea that Medicare for the patients who like it is bad. All I have to suggest is that Medicare for the patients who don't like it, they might benefit from my system. So you're trying to assume so much more that I have to cover and prove than I actually do. But I had a patient get charged $40 for 30 Flexeril generic and they're on Medicare. I get 1,000 Flexeril for $21. So Medicare is not helping those patients. It's not helping, you know what? The people who aren't on Medicare.
Medicare would allow them to bid that drug, so that's a moot point.
It's not a moot point because
In
it's,
single payer it is.
well, so if you get away with your magic wand and say whatever system, that, you know what, the VA gets to bid. And look at the poor results on VA patients. There's study after study talking about the wait lines for VA patients, how many VA patients are dying because they're not getting their care. So if you want to present the VA as your bastion
It's a
of,
regional job.
so some areas do a really great job and some do a really bad job. So that scares me when Medicare gets to be the sole dictator for all care and there's no competition angle there. So I'm always going to do what I want to do, which is practice independently. So I'll be outside of the Medicare system, but Medicare is not the most efficient. In fact, it's bankrupting our country because the pyramid is flipped. There's now closer to more Medicare recipients on than people paying into the system, and it's getting more expensive every year. So congratulations, you were part of the problem bankrupting this country because you're taking more out of the system than you put in, and the facts are there to show that. So we can't afford the system that we have if we go forward in
Thank you,
Medicare.
Josh. I appreciate you answering my question.
Any other questions from the audience? Yes, sir.
We want to lower the costs and then increase the care. To lower costs, it sounds like competition would be great. I'm talking to you. So how do we get transparency on costs? I mean, isn't that a problem? How do we on the cost for our care? That's a problem, isn't it? Transparency.
Transparency is a problem everywhere but the free market. It's hard to know what the government is spending on things. It's hard to know what your VA benefits are. It's hard to understand what Medicare covers and doesn't cover. And you'll find this out the first time you admit a patient for observation and you find out that they don't pay for their medication during observation. And so the patient gets stuck, Medicare, with a giant bill because you check the inpatient observation box, not the inpatient admission box. It's an administrative loophole. Now the patient's stuck with the bill. Or my personal favorite for colonoscopy patients is when you go in for a screening exam that's covered by Medicare, unless they do find a polyp, and then that's considered a diagnostic. And Medicare doesn't pay for the same rate diagnostics. So you wake up with a sore ass in the bill. So insurance has a problem with transparency. I tell all of my patients what things cost. I'll send them a screenshot of my supplier's webpage. They know all my costs are cost plus 10%. And if my cost is higher than the pharmacy because of coupons, I spend the extra money to build a system that tells me if the pharmacy is cheaper, because there's free market solutions out there that will track the pharmacy price and link to the coupons so that I have the most transparent pricing. My pricing with imaging isn't based on your copay, your deductible, your insurance plan, the day of the week. I have pre-negotiated a flat list I can hand it to any patient I want. For this body part, it's $400. For this body part, it's $440. You want it with contrast, it's $10 more. You don't want it with contrast? Great. So in this sort of system, we have more transparency because there's just fewer hands in the pot. Uber, pure transparency. They'll tell you what the price for that trip is going to be. Taxi cab, I can't find that out. More government-based system. Netflix tells me exactly what the price is going to be. So when the consumer is the one paying for it and not insurance or a government, then the provider of that service has to be very aggressive with showing what the service is, what you get, what it costs. So for us, my patients have no problem.
Dr. Weisbart, do you have any response to that question?
Yeah, so transparency implies that patients are able to make reasoned, highbrow decisions about the value of something. And patients can make decisions of what they're liking, but it's really hard for someone to understand the value of a colonoscopy. It's really hard for somebody to understand the value of a bone marrow biopsy when they're suffering from myelodysplasia. Those are really hard things for people to understand. And when they have to make the decision, am I going to spend, oh, that's going to cost, even with Josh negotiating, with his Superman negotiating skills, if I'm going to have to spend another $500 or $1,000 or $2,000,
We set that up earlier.
I'd rather not find out what underwear you're wearing. Too much information, Josh.
You want transparency?
No, I was not. My point is that it's very difficult for patients to make this decision of weighing. You suggested that people could decide whether or not they want to spend the buy-up to the contrast for an MRI. How in the world is a patient supposed to make that decision? How in the world is a patient supposed to just completely trust you, I guess, that you're sending them to the best MRI place because you've negotiated the lower price? You're talking about that as if that's something. No, they rely on you to make those referrals. They rely, if you tell them that they need something, and then they have to go back and decide, can I afford this? Most of the time they compromise their care because any incremental cost for people who are lower income, any incremental cost is a big trade-off. It's a big trade-off. Is Medicare perfect? I think I said at the beginning, no, it's not perfect. For example, of the examples you gave, I agree with. Those are things that need to be fixed. But to throw that away as the system that almost every group you'll look at, 80% of them don't want Medicare to be disrupted. 80% of seniors, 80% of people under age 50, 80% of people who make more than $60,000, 80% of people who make less than $60,000, 80% of women, no, actually 85% of women, and I think 78% of men, African Americans, whites, whatever way you slice the data, 80% within 5 or 10% of Americans want Medicare preserved. It's an incredibly popular program because the seniors remember when they didn't have it. They remember when they had to do what you're talking about, when they had to go door to door to find a physician that they could afford. And they didn't. They couldn't find one because it was too expensive. They're sick. It's too expensive to take care of them for $100 a month if they're sick. It's hard to do it that way. That solution erodes financial personal stability economically, it erodes the national health care, it erodes everything about our country that we need to rely on our citizens for.
Thank you, Dr. Weisbart.
This is paternalism at its worst. Did you know your patients are too dumb to make their own decisions? They can't decide for themselves what care is appropriate. Heaven forbid, during 12 years of education, you give any assistance to that. Let them take care of it, because your patients are just fools. They don't know what they need. They couldn't possibly be asked to make a complex decision on their own health care. So pat you on the head, tell you to sit down, and Uncle Sam will tell you what to do. We'll tell you if you need that bone marrow biopsy. Your little brain is just too small to understand these complex medical terms. No, I disagree with all of that. You are there as their physician. It is your job to be at the bedside, to explain to them, to be evidence-based, to help them to understand what they need, what they don't need. And sure, every patient will make a different decision, some good, some bad, but it has nothing to do with, the government being also wiser than you. This is paternalism that is scary.
I don't believe I said the government is wiser than people. I said
You
the
sure
government.
like-
What I said, and what I would continue to say, is that we have an opportunity to eliminate the financial barriers to healthcare. To eliminate the financial barriers to healthcare. And study after study shows that the nation can afford it and actually comes out financially ahead. It takes the responsibility for healthcare away from business, unfetters business to be able to compete internationally more. We can afford to do that and not trap patients into having to make these decisions between their rent and their mortgage and their next surgery and their next whatever. They do that today, and it's not
So did
right.
you drive the markup for Express Med script? Did you mark the profit down to 10% at any point in your?
So I'm clearly not here speaking on behalf
Oh,
of
of course
Express.
not, of course not.
And I promise you, they don't really agree with the strategy, not really.
Unrelated.
I'm gonna stop you there, Dr. Josh. Dr. Josh, I'm gonna allow another question. Sorry to interrupt. Yes, ma'am.
So I think it's sort of directed towards Dr. Josh, but we've heard about how there's a lot of government inefficiencies that's not really a great solution to taking care of people. And how you manage to negotiate things so that they become affordable, 35 cents for an ultrasound, that sounds amazing. And
EKG.
Sorry. And we've also talked about how, as a result, people don't have to pay as much for insurance because they don't really need insurance for that. What do you suggest is a solution for costs in the hospital for big operations, for chemotherapy, where you're not having to negotiate, for example, no one's going to give you a heart valve for 35 cents? What do you suggest is the solution?
What is insurance for?
Well, to pay for healthcare insurance.
No, insurance in general. What is your home insurance for? What role does it serve?
To spread risk.
To spread risk, right. Because my home is the most expensive thing I own. And no one's going to give me a cheap new home, so I insure risk. And medications at a penny a pill and EKGs at 36 cents aren't a risk. Hospitals are. My favorite example, life insurance. Few things actually worse than dying. So life insurance, though, is a true insurance actuarial model. We're taking something of a very high risk, the most, but a very low chance of happening. And we can balance out this very low cost, $100 a month, for my $2 million of coverage that hopefully my wife and kids and the companion will get someday in the future. So then car insurance being slightly different. I can get full coverage, so it'll cover every little thing, or I can just get catastrophic that covers if I hurt someone else. I choose based on the risk I'm willing to take. Homeowners insurance, exact same scenario. Health insurance is no different. I'm not arguing against the concept, because you're right, some types of care don't lend themselves to shopping. That's why you pre-shop for the insurance. My daughter was born with Down syndrome unexpectedly. Spent $160,000 the first 3 weeks of life. But that's why we had insurance. We know by the very nature of us living and having a baby that things can happen and be expensive. So we pre-purchase those things, just like I pre-purchased health insurance or home insurance or car insurance. So then drive the cost of that down because we have a more efficient insurance model. Like Malcolm Gladwell said, we have too much. So no one's arguing against the idea of insurance, but rather let the hospital find their efficiencies. But a hip surgery, you could argue, would be just as expensive. But if I'm saving families $3,000 to $6,000 per year on their insurance, in a couple of years they could pay for a hip surgery. Now they don't need a hip surgery now, but I potentially save them that much. If it's only $19,000 at the Surgery Center of Oklahoma. Well, through a hospital, that's $120,000 surgery. So it depends on your perspective. If you see hospital prices, which are always inflated. My partner Doug had a baby. Hospital fee was $17,000. The cash price, $1,900. 91% savings. So we have this blow in the American system of what is billed and what is actually reimbursed, what is actually worth. We bring those things together, you need less insurance, you have more efficient insurance, it'll cover more things at a lower price point. So that's the solution we recommend. Still have the insurance, but have it work smarter.
How would we do that? I mean, 'cause
Yeah,
You could say that, but why are we doing that right now?
We are. I'm doing that now. I sold a business yesterday for our clinic, 10 employees, and we saved them 34% on the cost of their insurance for 2015. So going forward, they've already got more money. They were getting a 27% quote increase. And they thought that was great because they were told to expect higher. So we've already renegotiated insurance down by this model. And that's where the physician's oath of do no harm comes into play, is that each one of you are responsible to the best model that you can for your patients and continually drive value up and drive costs down. Every year I get a better phone for the same price because of good business. Say, let's absorb those business ethics and give our patients more, work for that, because that will in turn show benefits on their insurance. So we are doing that. We just like to see it more widespread.
So we decided as a nation that if your kidneys fail, you have access to Medicare. Because we decided that we thought it was really not appropriate to let somebody go home without dialysis if they have kidney failure. That costs about $70,000 to $75,000 a year. So we do that. And we don't automatically pay for things to prevent that. So I don't know about you, but it seems to me really imprudent to pay $75,000 a year for kidney failure and not make their medications free, not make their visits to their primary care physician, to their renal doctor, to all the things they need, to not make that free. I would much rather pay for their $50 of insulin than have to pay for their 70, or just delay their renal failure by 2 years, and you've made some savings. So wait, let me finish this if I could. So to do it your way, those employers then drop most of their insurance and just get catastrophic insurance and reduce their premiums, and their patients then have access to you. I hope the patients of that employer like you, because you're the doctor that they have to go to. My wife, I might like you just fine, you know. My wife may not like you. My neighbor may not like you. I want to have the choice of going to any physician in the country. I want that, and most Americans want that. Your model locks me into one primary who will do everything they can do in my office. Well, hip hooray for you. I don't want you to do I want somebody else to do that laceration. I don't actually like the way you sew things. I want him to do that. And actually, you know, last time you casted me on this, wasn't so happy with it. I want that guy to do this. So your model gives me access to you, but it greatly reduces my choice as a consumer. A free market says that I can go to, and I can choose to shop at any place I want to. I can go to any doctor I want to. And then that doctor will get paid without having to worry what I can bring in financially, because we all bring in the same thing with that doctor financially. That's removing the alleged free market from the insurance industry, and we, I believe, agree that that's a problem area. Removing it from the insurance industry and introducing it really into the delivery side of healthcare, where every patient can pick where they want to go and not be locked into one primary care doctor.
So I'm pretty sure Medicare doesn't let you go wherever you want.
It
In
doesn't.
fact, no, I know it doesn't, because there's doctors not taking Medicare, and there's doctors who won't accept the low payment. So then Medicare doesn't pay for you to go anywhere.
95% of physicians accept Medicare.
95, 100?
Oh,
Pull up my calculator. So it's not everywhere. We have these false assumptions. And what did I present? Did I present an all-inclusive oligarchy where I rule? No, I presented a free market where each one of you are competing with me doing this model. I don't want to force every employee to go to the company doctor, and far from it. We don't do that. But we've built other doctors in our town doing the same thing. So now each one of us benefit because every employee has more and more access, more choices. That's what the market does. I can use Uber, I can use Lyft, I can use Hulu, I can use Netflix. It brings in competition. So this false argument that his wife may not like me, is that probably true?
Probably.
I don't know, I'm pretty sure. After tonight, I probably didn't think. But I would let her go to any other doctor and let her freely negotiate with them. Medicare doesn't allow that. That's why you have a two-tier system in Canada, because of the lawsuit. You have a two-tier system in NHS in England. So anybody who wants to take the really poor care that the government pays for, you can take freely and you get the same access to really poor care. You want to go outside of that system, you can, but now if you're of a certain class, you've already paid so much in taxes that you don't have the dollars to go somewhere else. So you're sort of locked in. The free market would maximize choice, would maximize opportunity for every patient to decide exactly where they go. And if I casted you wrong, you take your $50 and go somewhere else. You're not contracted to me. You leave me at any time.
Right, but you persuaded my employer to no longer offer insurance that covers primary care.
Right. So I saved you that much to go find another doctor doing exactly what I'm doing. And any doctor could do this model. So now they have that option to immediately go find any other doctor that they like and freely negotiate with. Nothing wrong with that.
Thank you all. Okay, so I have a lot of questions, and I think I'm going to limit to maybe 2 more. Yes. Or, sorry, you'll be next. Go ahead.
Well, thank goodness you saved me on those health insurance costs in Pullman where there's one doctor and I have absolutely no negotiating power. So your argument is that we should negotiate each patient's insurance individually to reduce their costs with the insurance companies? That patients save money on their insurance they're using their plan. But what was the point of the single care system and waivers for insurance if you assumed that everyone could afford insurance in the first place? You argued we should trust a free market of doctors. But there have been plenty of examples of doctors committing fraud in the past. It's not like it never happens, or that they have abuse incentive powers where they refer you, oh, you need a cardiac catheter. Here, I have this lab that's so cheap, you can go do it. You never needed one in the first place, though. Patients have so many resources to investigate their options when we're the ones with the knowledge and the background telling us what they need and what they don't need, and they do not have that education plan. I'm not saying they're not intelligent enough to figure out what they could do with their options if they know what they have and they know what's available. I'm saying we don't have all the information we might need.
Yeah, I mean, you know, one solution would be to have individual physicians negotiate with other individual physicians, where the leverage power you have is that I, as an individual physician, am not going to refer to you. You're not going to get the kind of price savings as you get when you actually have a system that can make rational fee schedules, equitable fee schedules, and actually set this up in a way that rewards primary care and manages this in a way that helps everybody.
Medicare pricing is rewarding. Is it primary care right now?
I never said Medicare is
Oh,
bad.
okay, just checking.
I never said.
So you're implying, yes, I'll agree with the statements you've made. There's examples of good business and bad business. And in fact, that is why we pull slowly in trust questionnaires about industries, because we haven't been first and foremost with our patients. We've been dealing with a third party and having to negotiate 2 masters, the patient and the insurance, and how do I get what you need and what will they pay for? I only have so many hours in the day because I'm seeing 30 patients. And there's examples of restaurants providing bad food. And what happens to them? They get a reputation. A bad reputation is hard to wipe off. They go out of business. And a doctor who gets a reputation for providing false evidence, for doing surgeries that are unnecessary, for tricking their patients, won't last long. Because me, as a physician, because I want to tell my patients who to go to and not who
The
they
specific
should.
doctor I'm talking about didn't get dropped off the market until the government investigated him.
That's
People
what
thought they needed those surgeries because he said they needed them.
And that's fine, there are examples, but again, that's one example. The fallacy is that applies to everyone. There's Enron. Enron was a very bad company. And actually, other companies turned them in because they saw their practices weren't matching up. So the majority, yes, there'll be ebb and flow of good and bad. Percentage-wise, so it's like a side effect to a medicine. One person had a bad reaction with Cinepril. We don't quit using Cinepril. So we find a balance there where your job, your coveted, sacred role in society as a physician is to guide your patient down. And patients will be very sensitive to that. If you lie, misinform, abuse them, I tell you, that reputation will spread. So it behooves you to do right by every patient. Those who do that well will succeed, and those who do that poorly will fail under any law.
Yeah, but I don't want to be the one person who trusted my healthcare to Chipotle.
That's again a false argument, because Chipotle isn't a medical thing. There's not a medical franchise. You can still go Chipotle and trust or not trust that they'll give you E. coli. So you have to decide as a customer. There's only one way. Even under a universal payer system, you're going to have to decide what doctors you trust and don't trust. So the trust question is there under any model. The free market gives you the option to go and work if under a universal payer system, they say, you can't have this medicine for breast cancer. And you go to the next doctor and say, is that true? Do you know if it's true or not? If they're all pulling from the same playbook? I'm outside of insurance. I have no master. You're my master. The patient, the consumer, I have to do right by you. I have to be able to prove that. Here's a resource, here's Mayo, here's Up to Date, here's Cleveland Clinic. This is why I think you should be on status. My patients question me all the time because they want education, they want to understand, and I respect that. So that's the role, but that's the role under either model.
Thank you, Dr. Josh. We're taking one more question. Sorry. And then we're going to wrap it up. Go ahead.
First of all, I just want to say thanks a lot for an entertaining debate.
Close to survey.
And here's my question. So I'm one of the bright-eyed, bushy-tailed med students in the crowd.
Good.
And I hope to be a family med doc taking care of the poorest of the poor in the future. And the way I see it, well, first of all, patients I've encountered, some are so poor they can't afford a $20 copay at a sliding scale community clinic, let alone a $600 a year retainer plus insurance, things like that. So and where I'm sitting and dealing with those patients, one solution is a single payer where they wouldn't have to be paying anything, and another is a system where they would have a retainer and insurance that I know that they can't even come close to affording. So I'm wondering where a concierge solution leaves the poorest of the poor.
So those poor patients already have a single payer system. They're Medicaid. We already have it.
You mean Medicare?
Medicaid, yes.
With all in Missouri.
Not this city.
Yeah.
Yeah, not here.
What?
Not in 25 states. We didn't expand Medicaid.
You did, just because you didn't expand Medicaid doesn't mean you don't have any Medicaid.
Pretty much, yeah.
You just didn't expand it. They wanted to expand it to, yeah, so it's still there, there's still a system in place. But that's at the grace of all the other taxes. So there's always a limit. They have no money. That's a hard market to sell to, right? And so that's where charity and things. We've had churches who come in and use our services because their charity dollars go 20 times farther when they're buying a CBC at $2 than at $50. And I would say that the government, when doing Medicaid, should be utilizing free market approaches like this. Even ACOs have been documented that if they have a strong primary care base, they have cheaper revenue, or cheaper, better care. So why wouldn't they involve direct primary care and give those poor individuals unlimited access? Why make them drive to your office? They don't even have a car, but they might have a phone because there's support systems for them to have a phone so they can get to work and call them. But now they can call you. That's cheaper than driving to you. That's cheaper than paying a copay. You have to find that model. Now, you can't run a whole model on that, but you might run a charity model, you might run a corporate sponsored model, you can do anything. We've worked this math down to $10 per patient per month, but I'll tell you, we're cheaper than the federally funded free clinics in our town. They have a sliding scale up to $45 per visit and up to $100 per procedure. But those patients coming to my office saving money, because I'll do that same procedure, a joint injection, a biopsy, for free. So they're coming to direct care, concierge medicine, and getting a better cost value product. So you're in charge of that, running your business. My goal is to make $200,000 a year. If your goal is to make 80, your price structure is very different. And I've helped doctors do that. So you can't say the system needs to fix it because you want to take care of a different group of people. You fix it for them. I'll fix it for my patients. But I was on the radio with a doctor who was leaving med school teaching position to go to an impoverished area. And my patients called back up and they said, that doctor made it sound like she was better than you because of that. She goes, do I not deserve good care just because I'm not poor? Do other people not deserve care? All of our patients deserve care. You choose who you take care of, I'll choose who I take care of. But that's, or we choose not to take care of any patients because we went administrative and then retired. That's each one of our rights in this position. So I fully embrace that. And you'll do the wholesale medicines and you'll do the wholesale labs because they're so much cheaper than anything else you can get. It's cheaper than filling out all the paperwork for free medicine from the drug companies because that takes so long and is so infrequent and broken. Like you can buy 1,000 of Citadel for $8 so and give it to your patients. So you're in charge. That's the power. I think that's the scary part. Is if it really is up to us. We can't blame insurance. We can't blame government. We can't blame anyone else than us. We're the gatekeepers of care. We're the ones in front of our patients. We're the ones charged with finding out the best way to get high-quality, cheap care. If a universal system happens, okay, but that's going to take a lot longer. Are you going to wait for your patients to get really good care because the country hasn't voted on universal health care yet? Probably not. You're going to go out and do the best job you can. Because you are bright-eyed, bushy-tailed, appropriately so. You should be. That's the goal.
So I'm going to try not to take this debate, but just set the record clear. You know, I see patients at least once a week. I volunteer at 3 clinics and safety net clinics around the country, and certainly at least every week here. And I still do this.
600 a month?
I'm a little older than that.
No, but the morality is you can choose how many patients you take care of.
So 600 patients a month, to come back to that point, still means that we need 4 to 5 times as many physicians. There's no way around that. It's simple, man.
That doesn't change anything. That says the market needs more physicians. That's like saying Uber's demand is higher, we need more drivers.
Well, how are we supposed to get 5 times as many physicians quickly enough to do what you're
The
talking
market
about?
will drive that. But A, I disagree with that math because I'll be more efficient with I've got doctors in our town taking care of 4,000 or 5,000 patients, and they're too busy to spend more than 5 or 10 minutes with each patient. So all of my patients get my time. And there's plenty of research to show that 40 to 50% of physician referrals are unnecessary because they're too busy. So that means I'm referring less. I'm doing more procedures. They're getting more care. I'll do the best job for my 1,000, or 600 patients, but it'll be the equivalent of thousands of visits. No urgent care. You don't go to the ER for, 80% of what goes to the ER is for acute, non-acute stuff, non-urgent things. They don't go there. They come to me. So we need fewer physicians, less drain on the system. Fewer doctors burning out, retiring early. If it was such a great system, we would expect you to be in it still. And so to say we're not still in it speaks to all the physicians I talked to burning out. New study, Medscape, last week, 50% of doctors suffer from burnout. That's the current system. So I would argue 2,000 or 3,000 patients is too many. That's not a sustainable one. 600 to 800 patients, pediatrician would do 1,200, would be fine. Let each doctor decide for themselves. So they say we need more restaurants. People will make more restaurants.
So I'd like to close the debate and put the audience up for the vote on who won, and we'll give it a couple minutes, and hold on one second.
So we have a different link to get to the post-debate question. If you want to fill out the survey again.
I did.
You guys called somebody in the audience.
Yep.
Deliverance in your acute clinical acumen means that
Yep.
those who are. Well, we right there. Those who are.
Well, it's not the only thing.
But that's enough.
Well, but I'm
Publicly spoken.
you're.
Actually,
Okay, so before this debate started, when we asked the first question, we had 23% agreeing with the statement, which was, do you think single-payer healthcare is right in the United States right now?
23 people, percent.
Thank you, 23 people, 23 entities. So it was about 50-50, 54, 45. Post-debate, drum roll please. You were responsive, I'm sorry. I may have cut that short. Seemed to flip, about 6%.
Congratulations.
So before we go any farther, let's take time to thank Dr. Weisbart and Dr. Joshua for coming out tonight.
We really enjoyed your passion for this debate. Thank you so much. We hope that we can all be friends.